Today, I will talk about what kind of information do we get when it comes to screening. I will talk a little bit about the difference between what we call prevention and early detection screening tests. And I will talk about all-cause mortality in a meta-analysis of randomized controlled trials on cancer screening. And I'm going to provoke you a little bit by asking if data from randomized trials are still valid, and talk a bit about modeling studies and observational studies, and how the finding of all-cause mortality in screening has implications for cost or just effectiveness estimates. And then I'm going to draw a conclusion. This is from the UK. I'm using some examples from the UK since we're here today. And as you can see, screening saves lives for sure. Help us help you. And this is just a quick Google search yesterday, and all of this came up, just popped up, the first things that popped up. So this is what we're told: screening saves lives. So in order to go into a little bit of more details, we need, I think, to classify cancer screening in two, let's say, groups. One is prevention and one is early detection. And the goal of prevention screening, and I'm only talking about cancer screening now, so if I say screening, I talk about cancer screening. So the goal of prevention screening is to detect and remove precursors of cancer. And the goal is to prevent cancer and reduce cancer death. Early detection cancer is to detect cancer at an early curable stage, and then hence to reduce death from cancer. But that depends on treatment. So if treatment cannot be provided, there is no effect of early detection screening. Or if treatment cures everybody, there is no reason to screen for early cancer. And when I talk about prevention cancers, I talk about sigmoidoscopy, colonoscopy, and I talk about cervical cancer screening. And sigmoidoscopy, and I don't have data on colonoscopy yet because there's only one randomized controlled trial published, and it was 10 years of follow-up. But we anticipate that the data from the next follow-up will come in about a year or so. But one might think that the effect of colonoscopy is as good as sigmoidoscopy, perhaps better, we'll see. So sigmoidoscopy decreases incidence of cancer by 1 absolute percent, 20% relative, when you compare those who are screened with those who are not screened. And when it comes to reducing death, the relative risk reduction is 25%, and the lifetime death risk of colorectal cancer is 2%, and it's reduced to 1.5%. When we look at the data for cervical cancer screening, and there's no randomized controlled trials backing the evidence for cervical cancer screening, there is an incidence reduction relatively of 50%, going from 2% absolute risk to 1%. And when it comes to death of cervical cancer, it's reduced from 0.7% to 0.5%. So you see that prevention tool screening tests reduces incidence and reduces mortality from cancer. So what about early detection tests? And some of you might argue that blood and stool is not an early detection tool, but that's what it's meant for. But it's usually, if it's positive, it's followed up by colonoscopy, which is a prevention tool. So I mean, you could classify it perhaps in both ways. But what we see in blood and stool test is that you do not reduce incidence. You don't increase it either, because usually it's followed up by colonoscopy, and then you detect adenomas, and then you reduce the incidence of cancer. But it reduces death from 2% to 1.7%. And we look at mammography, you see that it increases the incidence from 9% to 11%, and you reduce death from 3% to 2.5%, death of breast cancer. Prostate cancer screening we've heard a lot about, so this is just a repetition. You increase the incidence from 9% to 13%, but you also reduce risk of prostate cancer death from 3 to 2.7%. So this is all good. But what about overdiagnosis? What are the harms? So definitely you all know the harms of overdiagnosis, and I'm going to walk you through it a little bit. So overdiagnosis is defined by me today as finding a lesion, it could be benign or malignant at screening, that would not proceed to give symptoms or cause death. So why is overdiagnosis a problem? Well, we can't distinguish overdiagnosed lesions from lesions not overdiagnosed. And maybe in the future we can, but maybe not. So this is a real problem that we're facing. That was really pointed out by Michael in the previous talk. That means that we are treating lesions, or we are removing precursors. And it could be by surgery, it could be by radiation therapy, chemotherapy, other measures. So a significant number of healthy people undergo unnecessary treatment or removal. And this is the backside of screening. You reduce death from the cancer, but you also harm a lot of people. So how does this balance out? So overdiagnosis in prevention, it seems on the first thought as less, because you only remove polyps, adenomas. We're not talking about cancers. We're overdiagnosis, polyps, adenomas, cervical intraepithelial neoplasias. But this harms more people. Many more people will be overdiagnosed with prevention tools than with early detection tools. But on the other hand, you have less invasive treatment or removal for the precursors. And then the benefit, I would say, is that you also reduce cancer incidence. Early cancer detection detects cancers. And as we know, the treatment and the harms of treatment from cancer is larger for the individual than removing, for example, polyps. But, and I'm going to show you this as a thought, because I came over this publication some years ago, and this is based on Norwegian patient registry. And this is the number of patients being, or the number of patients who undergone cervical condensations from 2010 to 2017. And you can see it's increasing. And I estimated the risk of condensation from age 25 to 45 years old, and the risk is 1%. So 1% of the population will undergo cervical condensations. And you can say, oh, well, does that matter? It's just, you just remove a cone from the cervix. That's fine. No, may not be so fine, because 2017, 1,376 preterm births happened among women undergoing condensation. This corresponds to 90,000 people in the UK, or women in the UK, and to 15,480 preterm births. So when we talk about the consequence of overdiagnosing precursors, intraepithelial neoplasias, down the line, the consequences may be preterm birth, with all the consequences for that baby and that new individuals. So when we talk about screening, we need to balance, we need to think about the benefits and the harms, the consequences along the line. So to sum it up, the harms of overdiagnosis is that none of the individuals with an overdiagnosed cancer or precursor will benefit. But many of them may experience harms such as testing, from the testing or removal, such as colon perforation or bleeding, septicemia after transrectal biopsy, preterm birth, as I just showed you, and from treatment, lymphedema, coronary heart disease, neuropathy, fatigue, cognitive impairment, neurotoxicity after chemotherapy. The list goes on. And what we've seen in Norway, and this does not only apply to overdiagnosed cancer patients or breast cancer patients, it applies to breast cancer patients. 1 in 3 breast cancer patients do not return to work after diagnosis. Imagine a life when you can't be able to work. That's a downside. So that's why it's interesting to, when we look at screening and when we look at longevity of life with screening, you need to not only take care of those people who benefit. Some people benefit, definitely benefit, as you can see here. Can you see the arrow? No, you can't see the arrow. So on the green part, you see the benefit. And on the red part, you see the harms. So when cancer screening is advocated to save lives and increase longevity, they do not really give you the message that we also harm people. So we need to look at all-cause mortality in people who underwent screening and compare it to those who did not. And I've told you the harms of screening, and it could be that life is shorter due to the harms of screening. It could also be that cancer, a lot of the risk factors for heart disease, for example, is the same as the risk factors for some cancers, so that could also play a role for not prolonging life with screening. So we did a meta-analysis, and we looked at all-cause mortality, and these trials are included in our meta-analysis. And this is all the trials that are out there for different kinds of screenings. And the main result is this. The line, the vertical line, that's non-days of life. And on the x-axis, you see the days of life gained and the days of life lost. And we chose to use not years, but days, because the years are so few that in order to show you the difference, we needed to use days. And the only significant screening test that was sigmoidoscopy, who saved, on average, 110 days per person who underwent screening. For the rest of the screenings, you see the confidence interval is the arrows. None of them are statistically significant, although there is some signs that lung CT, PSA, colonoscopy may gain lifetime. And this is, I would say, a contrast to what we are hearing about in the campaigns. So we did not really find any significant, not statistically significant, but maybe when you talk to people, if you save 110 days for sigmoidoscopy screening, for mammography screening, you save none. It may not be worth it. And we may need to convey that to our patients. And why do we not find a reduction in all-cause mortality? I've touched upon it with the harms of screening. And also I mentioned that the competing risk of death, that the cancers we screen for have shared risk factors with more prevalent causes of death, such as cardiovascular and metabolic disease. We also know that cancer patients have a higher risk of suicide than the general population. And of course, when we screen, we find something. We may find an incidental finding, and that it might be harms due to that along the line. So that may be a reason. But a lot of people will claim that the randomized trials are underpowered to show a reduction in all-cause mortality. And that might be true, but still, if we powered it up, do we really believe that the average or the average mortality would be not within the confidence interval that we had, which is only some days, 110 days anyway, so it's less than a year. So it may be that that is true, but still, it's not really a significant, or it may not be a significant number for people. Some may claim that the follow-up is too short. The follow-up in these trials were between 10 and 15 years. Yeah, maybe, but we're screening people who are between 50 and 70, so, well. And then, of course, you may argue that we use the intention to treat analysis, and that's what we have to do because that's where the people are randomized, and those two are the comparable groups. And some people may say that let's model the effect, and let's use large observational studies, and I'm going to give you some arguments for why I think we should not do that. So I'm going to give you an example of a modeling study that was recently published along the United States Preventive Service Task Force's new recommendations on breast cancer screening published in 2024. And the new recommendation now says that they do recommend biennial screening from age 40 to 74 years old. And this was based on the randomized trials done several years ago, and then the observation that in the US it was an increasing incidence for women younger than 50. And also they wanted to model the effect because the technology they use today is very different from what they used back when the randomized trials were done. And what they concluded is that the balance of the evidence tipped in favor of starting a screening at 50. Previously, it was at age 50. And what they modeled, as you see here, they modeled life years gained from age 30 to end of life. They modeled attendance of 100%. And what they found is in the red box, they found that they gained 114.6 to 170.1 per 1,000 women years, life years. What does that mean? So I work as a physician with patients, and they don't understand per 1,000 women. It's hard. So what does it mean for me? So they modeled that the lifetime gained by screening, assuming 100% attendance, following people to the end of life, which is up to 100 or 106, I think, in the US, they gained 42 days or 62 days, depending on the screening tool. And we found 0 days. But you see, our confidence interval is pretty large, so you may say that 0 days and 42 days is the same, or you might argue that the randomized trials compare like to like, and you don't assume 100% attendance, and you follow people for a certain time. You don't extrapolate the data. You look at all-cause mortality, whereas the United States Preventive Service Task Force, they assume that reduction you found in breast cancer death corresponded to reduction in all-cause mortality. So you might argue both these two sides. So the modeling may be a solution, but be skeptical. Look at the assumptions. What are they modeling? Is it true? Can it be true? And then some people argue, let's follow people up in the society where we are screening people. And I'm going to give you an example from one of our trials, the Norwegian colorectal cancer prevention trial, which is a sigmoidoscopy screening trial. And this is what we found when we compared all-cause mortality. When we compared the screening to the control group, the all-cause mortality reduction was a non-significant 3%. And most of you would argue it's none. It's not a difference. So it's no difference in all-cause mortality between the control group and the screening group. But that's a randomized controlled trial where you have a valid control group in the population. What do you have when you start a screening program? You have attenders and non-attenders. So we broke it up just for fun to see what would the difference be in all-cause mortality. And the red curve is the non-compliers, the blue curves is the compliers. And when you compare those with overall mortality, you get 60% to 35% higher mortality in the non-compliers. So if you assign that effect to screening, you have a huge effect of screening, but when you did a randomized trial, you saw there was no difference. So be cautious. It may not be valid, a comparison of compliers and non-compliers. So it's really, we need to trust the randomized controlled trials. That's my main take-home message. So what does this mean for cost-effectiveness analysis? And this is an example of a cost-effectiveness, or not a cost-effectiveness, but analysis on quality adjusted life years in breast cancer screening that we did. And this is screening 100,000 women aged 50 to 69 years every other year, and we compared it to no screening. We assumed that 20, 50, and 80% of the reduction we saw from breast cancer mortality was transferred to overall mortality. And when you look at this, and we also included overdiagnosis in this analysis, and we had different levels of overdiagnosis ranging between 75 and 20%. And you see there's quality loss when it comes to, it's a loss in quality when it comes to overdiagnosis to be expected. So if you don't include that in your analysis, you're only going to have the gain and not the loss. It ranged from 1,670 to minus 4,809. What about the gain? So we assumed mortality reduction of breast cancer of 10 to 30%. And we assumed, as I said, 20% reduction in overall death, or 50% reduction, or that to transfer to 20%, 50%, and 80%. This is difficult. Read the paper. But we assumed no linearity between cancer death and overall death, assuming 20, 50, and 80%. And of course, the gain is going to vary with that. But looking at our numbers, this is the maximum we gained was 3,493 QALYs to a loss of 4,000, more than 4,000 QALYs. And look at the US Preventive Service Task Force. When you use the numbers per 100,000, it's many times higher. So be cautious. Read all the assumptions, what is going on. So implications for breast cancer mortality, transferring it directly, or cancer mortality, or transferring it directly to all-cause mortality, it's not valid. So we need to have honest information and honest campaigns. And this is my suggestion that for what a campaign could look like, being inspired by the UK information material. So there's little to no gain in longevity when it comes to cancer screening. Cancer-specific death cannot directly be translated to increased longevity. And cost-effectiveness or effectiveness models need to include all-cause death. And when we look at mortality and when we do screening trials, please include all-cause death as an endpoint. Thank you.